Dr. Adrian Mejia. We're so glad he's doing this presentation. He is a future child psychiatrist. He is currently in our Child and Adolescent Psychiatry Fellowship. He's in the first year of his fellowship. He also will, so in a couple of years, he will be graduating as a general psychiatrist and a child and adolescent psychiatrist. He went to medical school in Guadalajara. He went to graduate school in the biological sciences here at Texas Tech. And he is a hometown guy. He is from UTEP undergrad. So I know we have a lot of your colleagues from UTEP that sign on to our presentations, and we're very happy about that. So without further ado, I'm turning it over to Dr. Mejia. Thank you so much for joining us, everyone. And thank you, Dr. Mejia, for presenting.
No, thank you, Dr. Martin, for having me. And thank you, everybody, for joining this presentation. As we're going to be talking about today about the oppositional defiant disorder. I believe you have heard about oppositional defiant disorder. And this type of disorder, as we know, it's a disorder in which children and adolescents demonstrate like aggression and purposeful behavior. And also it affects from between 10 and 20% of school-age children. And this kind of behavior put the children and adolescents in trouble with their families, at school, with their friends. So that what they have is they have problems with authoritative figures. And as we know, through the development of the children and adolescents, it is normal to have certain disobedience, certain defiance, but when it is out of proportion, when it's more frequent than usual, then it can be oppositional defiant disorder. And they resist this disorder, they resist conforming to others' demands, and their behavior is characterized by negativity, hostility, and defiance. And right now, I'm going to play a brief video about the oppositional defiant disorder.
Understood that children and adolescents may display a degree of opposition as they develop and find their place in the world. However, when excessive, this can be something more serious. An easily annoyed child who frequently loses his temper concerns us. When this same child purposely annoys others, argues, and refuses to comply with authority figures, and takes no responsibility for his behavior, our concern rises. These are symptoms of a condition called oppositional defiant disorder, also known as ODD.
Okay, so this is a quick video to summarize what I've said so far, and let me go back to my presentation. Okay, so it is important to talk about the DSM-5 criteria for the oppositional defiant disorder. And while we are discussing it, just have in mind a differential diagnosis, okay? For oppositional defiant disorder, we have a pattern of angry, irritable mood that is argumentative, defiant behaviors, or vindictive lasting at least 6 months, as evidenced by at least 4 symptoms from any of the following categories, and exhibited during interaction with at least one individual who is not a sibling. One of them is the angry, irritable mood, and we have 3 different characteristics. That is often loses temper, is often touchy or less or easily annoyed, it is often angry and resentful. That one is argumentative, defiant behavior, and often argues with authority figures, or for children and adolescents with adults. Often actively defies or refuses to comply with requests from authority figures or with rules. Often deliberately annoys others. Often blames others for his or her mistakes or misbehaviors. In regards to vindictiveness, they has been spiteful or vindictive at least twice in the past 6 months. For individuals that are 5 years old, the behavior should occur at least once per week. Okay, and then we have the disturbing behaviors associated with distress in the individual or others in his or her immediate social contexts, like family, peer group, work colleagues, or it impacts negatively in social, educational, occupational, or other important areas of functioning. The behavior do not occur exclusively during the course of psychotic, substance use, depressive, or bipolar disorders. Also, the criteria are not met for disruptive mood dysregulation disorder. And we have specifiers that it can be mild when it occurs in one setting. It can be at home, school, at work, or with peers. Then it's moderate when it occurs in two settings, as I mentioned before, the ones that I mentioned before, or severe, that is in three settings. Now, with this in mind, what differential diagnosis do you have in mind? Just we're going to discuss about the differential diagnosis that we can have. Epidemiology speaking, oppositional defiant disorder has a prevalence of 1% to 11%. It makes an average of 3.3%. And it changes the diagnostic criteria, account for some of the variation in the reports that have been made previously. Prevalence can also be influenced by social and socioeconomic status, per socioeconomic status families. And before the age of 13, it has been found that it's more common in males than in females. Now, talking about comorbidities, one of the most common comorbidities that we have in oppositional defiant disorder is the attention deficit hyperactive disorder. This is the most common one that we have seen. It can be difficult at times to distinguish or to differentiate the behaviors between these two, because children with attention deficit hyperactive disorder, as we know, they have poor attention, poor compliance, they're disobedient, and other possible considerations. The differential diagnosis can be separation anxiety and also generalized anxiety. And with these kids, when the separation anxiety, when the kids are being separated or from their parents or their caretakers, they become anxious and they're defiant, they're fighting towards authority figures. Okay, and similar consideration should be given for mood disorders, as an antagonistic and disobedient behaviors are often associated features of children with mood disorders. We continue with the differential diagnosis, and it is critical to distinguish the oppositional defiant disorder from the developmentally appropriate oppositional behaviors, as we mentioned before. The studies have shown that the diagnosis can be made reliably in both preschool children and adolescents. Oppositional behaviors that occur as a transient reaction to specific stressor are more appropriately diagnosed as an adjustment disorder. And the ODD behaviors do not include physical aggression or violation of the law, as previously noted by the youth with conduct disorder. The inattentive, impulsive behaviors of attention deficit hyperactive disorder can often appear to be oppositional, but are not usually willful defiance. Transient oppositional behaviors and irritable can be seen in reaction to stress, such as family are moving, they are having divorce, there is economic stress in the family, physical violence, illness, and also with kids of sleep deprivation. We have the different factors, etiological factors and risk factors that are present when we have children and adolescents with oppositional defiant disorder. We consider the biological factor. When we have, it has been seen that certain families and the siblings, they have, and also relatives, they have some of them have the positional defiant disorders, and this gives us impression that the genetic factor plays an important role. And there has been studies made about biological studies made, and this genetic studies, it has been found that ODD is associated with the androgen receptor gene and the three dopaminergic genes that we have here mentioned. In the psychological factor, we consider temperament, and is often used to explain difficult behaviors in children. But the evidence for a relationship between temperament and later behavior problems is mixed. Most of the longitudinal studies considering temperament generally support the view that associated risk factors develop of later oppositional behaviors. And there's a theory, the attachment theory, that offers a plausible explanations for the development of oppositional behaviors. Is we have read that it is really important to develop to make a secure attachment between the parents and these children, and it will be like a protective factor with for the kids in the future to not to develop like oppositional defiant disorder. Uh, the oppositional defiant disorder, as I mentioned, has been associated with insecure attachment, but only in school-age children. The sociological factors, we have many risk factors. It can be the lower socioeconomic status is associated with, it's a risk, but it's probably because there is a lot of stress in the family and that it results in dysfunction in the family due to having socioeconomic problems. Many other families have related or correlated, like for example, when they have poor parenting practices, parental discord, when there is physical violence, verbal violence, and other antisocial personality disorders too. And it has been found that mothers of children at increased risk for oppositional and disruptive behaviors report feeling like they're not able, to deal with to have a solution with the kids present with this type of problem with their behavior. So it is important that most of the developmental theories have shown that parental response to normal oppositional behaviors in toddlers is central in shaping either adaptive social skills or increased defiance. So keep that in mind. The course and prognosis for the oppositional defiant disorder, it is typically the age of onset is at 6 years old, when most children have outgrown earlier normative oppositional behaviors. The oppositional defiant disorder demonstrates high stability over time, and stability correlates to the severity of the symptoms. Most children with ODD will not go on to the other disorder, the conduct disorder, in higher numbers of ODD symptoms than of those who did not develop conduct disorder. The symptoms of ODD typically persist after the onset of conduct disorder. In preschool age children, the presence of ODD is also predictive of later diagnosis of ADHD. As complications, children and teenagers, just can imagine with oppositional defiant disorder, where they have difficulties with authority figures, they have like defiance behavior. Okay, they may have problems in school. They have poor school performance. They may be impulsive. They don't have control. They can develop into substance use disorder. They can also attempt to commit suicide. Many children and teens with oppositional defiant disorder also have other mental health disorders such as ADHD, anxiety, depression, learning and communication disorders too. For prevention, also I'll talk about this later a little bit more. It has been the most important factor here. It's to try to engage the parents. To also, it's important there are different programs that have been created for parents to guide them to the process when the kids have been diagnosed with oppositional defiant disorder. And so there are like different programs that I'll talk later about, like it's called the Wonder Years. There are many programs that have been created, and I will talk about later. Now, what treatment should be considered for the oppositional defiant disorder? There are no medical treatment. There is no medical treatment for oppositional defiant disorder. When we have other concurrent disorders as ADHD, we can we can give stimulants, as we know. For anxiety, we can provide SSRIs, but per se for ODD, oppositional defiant disorder, there is no medication at this time. It is important that when we interview children, that we we have to interview the children with their parents, and they have to feel comfortable when we talk to them. And at times we have to separate the parents and the children when the parents are becoming angry, irritated, and then they're talking bad about the kid. So at that time we can separate the parents and the children when we do the interview, because we had to do a full psychiatric interview. And we also use different scales that we use to rule out or really in certain disorders. We have for example, the SCARD scale for anxiety. We have the Vanderbilt for ADHD. We have the Columbia for depression. And there's one, the Iberg Shell Behavioral Inventory, that has been used for teachers in order to report disruptive behaviors in children and adolescents that have associated with ODD and conduct disorder. One of the treatments the treatment for the ODD is psychotherapy. There are numerous interventions that can be made for parents and for the children that have been diagnosed with ODD. The parent management training is one of them. It's a problem-solving skills training that have demonstrated the greatest efficacy with ODD. Parent management training indirectly affects child behavior by improving parent skills in dealing with negative acts and promoting desired behaviors. It's a behavioral parent training. And we have other ones like the child problem-solving skills training. That is also one of the training that can be used. And we mentioned that we should do a thorough evaluation of the patient. We have to do all the questions. We also have to involve the teachers. That way they can give their input about the children and adolescents. Okay. So we mentioned about the behavioral parental training, and models for delivering parents training involve a therapist working with the parents. They teach a variety of behavioral strategies. The parents then apply these strategies at home. They troubleshoot the use of each strategy occurs within the context of each individual family during each therapy session. Parent training may be offered in combination with behavioral school consultation and with child-focused interventions, such as skill building groups or cognitive behavioral interventions. The parent training can be administered individuals with parents, with families, and the group format may be especially useful for parents who would benefit from receiving support from and or sharing ideas with other parents. So when we are doing therapy with parents and children and adolescents, we had to set treatment goals. In behavioral approaches, setting goals of treatment is an individualized and collaborative process between parents and therapists. Usually, the parents' initial goal simply involves modifying the child's behavior. However, in parental training, treatment goals include the parents changing their own behavior. Although this goal does not always need to be explicitly stated, some discussions of this is helpful. So now, what to do after we have a diagnosis of ODD? These questions arise, and then what is like to be living with the children with ODD? How to prepare your child's for school? What support can we offer to parents? And so for this, what to do after an ODD diagnosis? When the child is first diagnosed with oppositional defiant disorder, it's helpful for parents to learn as much of the disorder that they can learn for. It's a key concept here that parents to be involved to learn more about the disorder. Parents can learn methods for coping with the behavior. Parents programs can attend different programs. We have different programs such as the collaborative and proactive solutions. We also have the parent-child interaction therapy and the credible years. And it's important to find a therapist for the parents, for the children that work with them. Now, when the children are going to school, it is really important for parents to meet with the teachers or others that are involved in the children adolescent education. And they should be combined programs with school, and also the school with positive parenting. It's effective. Special education services can support accommodation for the children. There is also the 504 and also support from the school. And now, when we're talking about educating the children with oppositional defiant disorder, we should encourage the positive attention, positive enforcement, and we should avoid harsh punishment to the children. And as we mentioned, for therapies, we can use the cognitive behavioral therapy, the solving skills training, family therapy, parent management training, school-based programs, and social skills programs. When we have a child with oppositional defiant disorder, um, let's avoid power struggles. We have to pick our battles. Um, we have to provide positive feedback to the children. And also, there are different books that we can read about the oppositional defiant disorder. And the cornerstone for treatment of oppositional defiant disorder, as we have been mentioning, is the parent training, the parent-child interaction therapy, individual and family therapy, the cognitive problem-solving training, and another one would be the social skills training.
Defiant disorder.
There you go.
Someone will be diagnosed with an oppositional defiant disorder if there is a pattern of behaviors for at least 6 months and displayed towards someone else other than a brother or sister, meeting 4 of the following symptoms: losing temper, easily annoyed, often angry and resentful, often argues with authority figures, often defies or refuses to comply, often deliberately annoys others, often blames others, has been spiteful at least twice in the last 6 months. These behaviors are associated with distress in the person or in others in their immediate social context, and impact on social, educational, and other important areas of functioning.
And it seems like some chose option number 6. So you might want to explain the difference between 6 and 8 and why the answer is correct.
Okay, remember that for the oppositional defiant disorder, we should have the parent training, parent interaction, individual and family therapy, cognitive problem solving training, and social skills training. It's all of them. It's all together that will be a good treatment option for the patients with oppositional defiant disorder. You have to encircle everything.
Okay, perfect. And then also, Dr. Mejia, we have a plethora of questions. It seems that the audience is very interested in the topic. So Dr. Martin is managing the Q&A, but we might want to address some of these questions so that the rest of the audience can also hear the responses. Let's see, we have Dale Quest, who is asking, disruptive mood dysregulation disorder was not on the list of ODD comorbidities. ODD DSM-5 diagnostic criteria specifies severity. So if the distinction between ODD and disruptive mood dysregulation disorder is or is not on a spectrum of severity, and they are not as comorbid conditions, what is the distinction between the two labels?
You want me to, can I chime in there?
Yes,
Okay,
please.
Adrian?
Yes, it's okay.
So this is an important thing because all these things seem very similar. So how I think of them in my mind, how I separate them is disruptive mood dysregulation disorder is in the category of depressive disorders. So this is a diagnosis where you're having outbursts and very emotional episodes very often, at least several times a week. It's a childhood diagnosis, and it is long-term. It's a chronic problem. It's 6 months or longer. Usually it goes on for a long time before it's treated, but the trigger can be anything. Whereas oppositional defiant disorder can also include outbursts, but it is going to be in direct response to an authority figure pushing that authority on the child. And then a lot of people also ask about conduct disorder. Conduct disorder is in a much more severe category. It involves violence against others, destruction of property, fire setting, illegal behaviors that really harm other people. But it's of course, it includes as severe as rape and murder. So it's kind of analogous to the adult diagnosis of antisocial personality disorder. So a lot of times I see people putting conduct disorder because the kid is having behavior problems. So, but there is a big difference. I think they just picked too oblique or oblique of a name for that diagnosis. But hopefully that answers some of those questions. And then Ricky Estrada asked for a question that's very similar. How do you differentiate a child with ODD to one that has never had structure or discipline at home? And really, there is no difference. And the best treatment for ODD is a family treatment, teaching the parents how to interact in a smoother way with their child to get the outcome that they want. A lot of parents, when the first thing they do what their parents did with them, and if it's a harsh intervention and the child is kind of a sensitive child, they're either going to completely shut down and perhaps get depressed, or they will fight back, and that's what we describe as ODD. So every child is different in how they need to be guided in terms of discipline and cooperation. And a lot of times parents are just so stuck on what they grew up with, or sometimes the opposite of what they grew up with, because they didn't like how their parents did it. So really there isn't much of a distinction. Okay, I don't want to take over your whole presentation though, Dr. Mahia. You want to go on, and I'll keep answering the questions typed too. Okay.
Oh, we can we finished with the presentation. I think it was too fast for me.
Okay. All right. Should I talk a little bit more then about some of these?
Yeah.
We have never had this many questions. This is so great, Dr. Mahia. You are just generating all this interest and a whole new level of delving into all this material. So Rahila Hafiz, what may be the diagnosis if you see oppositional defiant behavior in a child younger than 5? I don't know if the diagnosis is super important no matter what the age of the child. I think, especially in the younger ones, for any age child too, you want to get help for the parents. And so how you interact with the parents and the way I usually approach it is I talk to them about, some kids are really easy. Some you give them a look and they'll do exactly what you say. Whereas other children, you give them a look and they just act out more. So every child needs to be disciplined and taught to cooperate with the family or the teachers in a slightly different way. So that's how I approach it. So if you can talk the parents into trying something different, but you have to approach them from, what you're doing isn't wrong. It might be great for another kid, but we have to work with your kid, and your kid is special and unique and that sort of thing. Let's see, Elsa Godding, another question. I think I learned years ago that ODD was in children under 18 and then in adults over 18. The diagnosis was antisocial behavior. Actually, it's conduct disorder in children and antisocial behavior in adults. Yes, that is the terminology. ODD, they don't really have an analogous one. I know someone else had asked a question previously, and I would, in adults, once these kids grow up and they still have the same behavior, they might be people that some people take a little longer to mature. It could be that. Psychotherapy might be a good treatment. You might want to look and screen for depression or another mood disorder and ADHD even as an adult, in order to try and find something that you can help this patient with. But if it's really just an attitude problem and it's kind of a learned behavior because they've always been oppositional and no one taught them how to cooperate, no one was effective at this, then psychotherapy would be a good recommendation. Unfortunately, most people don't come in as adults for this, but you might be able to catch some of these young adults that are still living at home. That technically they're adults, but mom still pays for everything. So that would be a good intervention. Matthew Luna has a question. What would be the procedure with a child who is not with their family if they have no family to help them in therapy? It would have to be an intervention with whoever they're living with. It doesn't have to be family. Of course, a lot of people are with the foster family. And then some kids live in a residential treatment setting or some other kind of group setting. So these family interventions can also be taught to any environment where a child is living. So it doesn't have to be their actual family. And a lot of I see kids learning a lot of these skills in school too. And so an educational intervention. I've had a lot of kids where the teacher is very authoritative. And so in a kid who tends to be oppositional, it's hard to becoming more direct and more authoritative just makes the situation worse. And so sometimes we can help teachers with that. Often it's teachers who maybe not all teachers want us to help them change their ways. Sometimes we can just simply change the kid to another class and they do a lot better. Let's see, I know we have a whole bunch of questions in the chat too. Let's see. Oh my gosh, we have lots. Does it take a therapist who specializes in CBT for ODD to successfully help families? I would say that virtually all therapists, if they are licensed, they are very comfortable with CBT. They might not be their favorite type. They might want to do something else. And by no means, I think there's a lot of different ways to come at a host of different diagnostic problems, behavior problems, emotional problems in children. I think the most important thing is that the therapist is trained well enough that they do have flexibility to use different types of treatment depending on the situation, depending on the response of the family. And many of the first sessions will just be getting to know the therapist. There's a lot of research that goes on about psychotherapy, and the number one predictor of whether a therapy will be successful is not the type of therapy, but it is the rapport with the therapist. So if you get these families back and they're like, that therapist is not for us, just explain that that part is important, and so you want to refer them to another therapist, a different therapist. And it's such an individual thing. Let's see. We also have a survey in the chat. If people could fill that out, that'll help them get your credit, but it'll also help us improve all of these. Here's another question from Tina Huseth. Conduct is when they begin to get in trouble with the law, manipulating to get what they want. Yes. So I guess that's a comment. That's when that's one of the lines you need to cross in order to go into conduct disorders, illegal, aggressive, violent behavior. Marcus Handling, since a lot of this involves therapy, including the parent, how does one provide this in a medical setting that requires billing? That's a hard one. Billing. I know there are a lot of things going on in the Texas legislature and nationally as well to change that. So the codes, and there are codes that but they're usually not used by the insurance companies. So insurance companies, hopefully in the future, will be more willing to pay for this sort of thing. So let's see, like, for instance, I was in the military, and so we use the same codes as everyone else for billing, but we don't actually bill, of course. So we can use any code we want. We often would use psychotherapy without patient present, and that's like a family therapy code. In the medical setting, a lot of primary care providers have been asking me about coding and the things that you all do in your own primary care clinics. And I'm going to research that, and I'm going to get back to you all because I don't know a lot about that, but that keeps coming up as something that you all need to know, because of course you're going to be able to support it more in your practice if the insurance companies are paying for it. So anything new that comes out, I will send out through the listserv, so that even if you're not in our region, you're on our list in terms of attending these. So I'll get back to you guys on that. I think at least 2 people asked that today. Melissa Escontrias, I'm probably saying your name wrong. Escontrias. She says, so from what I understand, you treat the behaviors like depression, ADHD, and anxiety along with the parent training. Yes, if you screen and you think, or even if you suspect that the child is having a depressive disorder, I would go ahead and, if you're the therapist, mention that to the primary care provider or to the parent, and hopefully they can pass it on. Usually primary care providers that work with children are very open to receiving all this collateral information that we in the mental health field want to give them. So, they're going to be too busy maybe to talk to you on the phone that minute. But if you're a therapist and you have information like this, it would be great to let the primary care provider know in an email or a phone message, and then they can call us up if they want to take a next step into something, into a more complex treatment. Maria del Carmen, good evening. Increasing coping skills using techniques such as role play, teaching about emotions and how to express them are very useful. And this is a good example, Maria, of what someone can do in their own clinic, whether it's primary care or a therapy clinic. That is, super important. Oh, and Tina says she didn't see the survey. You have to scroll up, I think, a while to see the survey. And then a question, do you see this diagnosis is being given more often when 2 or more behavior disorders are present? Usually I only give one diagnosis when it's a behavior disorder. Like if they're oppositional and they have conduct disorder, I just give conduct disorder. Now I'll tell you, in the grand scheme of things, in terms of treatment, of course, there are no FDA approved treatments for ODD or conduct disorder. And believe me, people have tried and nothing works. It is a psychotherapeutic intervention that is going to really solve that problem. So a lot of times they aren't the diagnosis that you want to focus on. Plus, these are diagnoses that carry a huge amount of stigma, and it might be, I would really encourage everybody to look deeper, do more screenings on kids that are behaving in a way that is not consistent with how they need to cooperate in the real world. I would look for depression, I'd look for anxiety, and that sort of thing. No one can see the survey. Are we sure that it got put into the all attendees category?
Yes, it's also on the follow-up email.
Okay. So for the survey, you guys will get a follow-up email and you can click on it then. I think if you scroll all the way up you know what? It says Jessia put the survey there, and it is only sent to the panelists. So we do need to put it again for all the attendees.
Let me go ahead and do that.
Okay, Raul's got it. I could probably figure it out, but then I would have to stop talking. And we have one more question, I think. Oh, it's a comment. Let's see. Hello, very helpful info. This is from Natalie Science. Thank you. Okay. Can children with ODD outgrow this disorder without intervention, or will it persist if untreated? It can be both. If it's to the point where it is causing problems in whatever setting and at whatever stage in life, then we would hope that they would get treatment. But often kids do figure things out on their own. They just might get there a little bit faster if they have help from a professional. Okay, there's the survey. I think we had Jessia in the wrong category. That's why she couldn't send to all the attendees. Sorry, Jessia. But there we go. There we go. And Raul has some comments about how to get credit. Oh, could you please, Marcela Frausto, Dr. Frausto is asking for our website. And overall, thanks for the seminar. Thank you for attending. And I think in the chat, Raul, I know you can put that. Oh, we have a slide where you can also do, we're going to put it up right now, a slide. Let's see, I think Dr. Mejia has to stop sharing for us to put it, right? Oh, yeah. So Raul can share. And so right here, you can use your phone and click on this, but this is our website right here. And maybe put it in the chat too, because then they can just copy and paste into their email. Or sorry, into their browser email. I get a little confused here. Yes, so there's our website and our phone number and that sort of thing. And one thing I want to also share with everyone that it is our program to help primary care providers, but really all providers that help, whether they're in psychiatry, psychotherapy, social work, or pediatrics, family medicine. We're trying to support all of you with these educational and our other programs and they're all funded through the Texas State Legislature. And guess what? It's legislature time. So you all attending these is some great information. I can say, well, today 121 people logged on because they want to know this stuff. And so it is looking very good, though, that our funding will be continued. And so I really appreciate you all, because the only way that things like this can continue is if, of course, everybody uses the services, and then we can continue to provide this. But this is a public health service directly from the state of Texas.
And Dr. Martin,
yes.
Just as a reminder, it's very easy to sign up. We can even sign you up within 2 minutes. The process, as I mentioned, is completely super easy. But that's how we track the numbers via enrollments and also via the calls, the consultation calls that we receive. So if you are making use of the services and have not enrolled yet, we would highly recommend that you do. That way we can start showing that in the numbers as well and continue the funding.
Dr. Salom had a comment. Thank you. That was great. I love that. That's a great comment. Thank you, Dr. Salom. And Elsa Godding says thank you. Thank you to our audience. Any more questions for Dr. Mejia or myself? I know, Adrian, a lot of people were asking for any screening instruments you can provide in terms of screening for ODD. And then we recommend the Vanderbilt for kids up to age 12 and the SNAP for kids older than 12, so the teenagers. They're very, very similar. They're almost exactly the same, but one is validated under 12 and the 12 and under, and one 13 and up. So I know a lot of you all are familiar with these instruments. And then of course the PHQ-9 or the SCARED is good for adolescents. Margarita Soto says, thank you, great presentation. Thank you so much, everybody. Yeah, this is the topic that we've had the most people log on to. So we will, and this will be on our YouTube channel eventually, maybe even by next week, right, Raul? If you have colleagues that you want to send it. So it'll be under the Texas Tech El Paso YouTube channel. And so you guys can search for it there.
Yes, and you're completely right, Dr. Martin. The videos will be on YouTube starting next week. Just give it a little bit of time as videos start trickling in from last year, from October. But we will have all the opportunities that we've had up to this point. And also we will include all the opportunities that we have up to June, and make sure that you're all adding the correct email address and the one that you're using most actively, because that's the one that we're adding to our listserv, and that's where we're sharing all of these opportunities and these news, as well as our newsletters regarding CPAN.
Yes, and we are also, we have a company called Trait, T-R-A-Y-T. And so the email will say cpan.trait or something like that, confirming your enrollment if you do decide to oh, Melissa wants your PowerPoint, Dr. Mejia. I always love when they ask for that. So yes, we can send that out too, if Dr. Mejia doesn't mind. I'm sure he'd be glad to share. We're just so lucky to have him. He's so great.
No, thank you. Of course, we can share. Yeah, we can share it. No more.
Yes, Sylvia Pitcher says yes, she wants that. Oh, and Elsa Godding says she likes the emails, so then she can put it on her schedule. That's great. So yes, we will. You guys are asking, so we'll send you more stuff. We don't want to overload people, but hey, if you guys are asking, we can send some more stuff. And thanks for letting us teach you today. And you can always email us directly, or you can email us from the Texas Tech website has everyone's email address too. So again, thank you so much. And everybody take care, and we will see you. Hey, even we have one, I think next week or the week after. I think the week after, right?
On the 25th.
On the 25th, and the subject is racial equity, right? Yes, racial equity in medicine. So that one should be a really interesting one. And that one is being presented by Michelle Oyeka, one of our residents. And she has spoken about this topic at a national level already. That's how we kind of snagged her into it. And she is also the same one who gave the substance use disorder lecture, if you guys had logged on for that. So she's a great speaker too. All right. Thanks, everybody. Take care.
Thank you.